شاء الله اليوم راح يكون الجزء الأخير من سلسلة البيسك dental implant course. Today I will discuss the surgical procedure. Basically, it starts with the anesthesia, whether it's the upper arch or the lower arch. Then the flap reflection. A 3-line pyramidal incision or a crystal incision are done. The mucoperiosteal flap is raised to expose the underlying bone or the ridge. If a flapless technique is planned, then a punch drill is used. I will start by talking about soft tissue and soft tissue reflection. Once the bone volume is assessed and the implant surgical option is identified, whether it's 2-stage or 1-stage, the implant procedure may commence. In the 1 or 2-stage approach, the soft tissue reflection is similar. A scalpel number 12 or number 15 is used to incise the mid-crystal tissues. At least 1.5 millimeters of keratinized tissue should be left on the buccal to this incision line. The incision line most often is extended through the interproximal and circular tissues of the adjacent teeth. This permits complete assessment of the crystal bone volume when the tissues are reflected. A periosteal elevator is used to make a full thickness soft tissue reflection and expose the crystal bone and a few millimeters of the lateral aspects of the implant site. The buccolingual dimension of bone is measured and confirmed to be greater than 7 millimeters in width. If the site is less than 7 millimeters wide, a division B membrane and layered approach bone graft are used to augment the site, either in conjunction with implant insertion or as a separate surgical procedure before placing the implant. Now the implant osteoarmy. So after the soft tissue is reflected, a 2 millimeter diameter pilot drill is positioned in the mid-mesiodistal and faciopalatal aspect of the ridge and proceeds 9 millimeter within the bone under copious cooled sterile saline. Then a 9 millimeter long force direction indicator is positioned into the site for evaluation. After that, the 2 millimeter diameter drill is reinserted to the final depth position. Most often, the drill prepares the bone 1 to 2 millimeter deeper than the length of the implant, of course when the opposing landmark permits. Then a 2.5 millimeter end cutting twist drill rotating at 2500 RPM under copious amount of cooled sterile saline is then used to beyond the final depth. The drill is removed from the handpiece and reinserted into the osteotomy to evaluate the implant site angulation. A 3 and then a 3.4 millimeter diameter end cutting drill then prepare the site for a 4 millimeter diameter implant. Of course, the final drill of each implant system may be a slightly different dimension. Once the final osteotomy diameter and depth is prepared, a bone tap is used in a low-speed, high-torque handpiece, 30 RPM, to form the threads within the bone for the implant. The threaded implant is inserted with a handpiece at 30 RPM. The soft tissue is approximated and sutured with a resorbable material, number 4 or number 5, around the permucosal extension or over the cover screw, depending on whether the tissue is at the right position or is being augmented. Here you can see an implant drill kit with color coding. Most often identifies the drill sequence and the final diameter related to each implant size. So basically we begin the implant insertion with a starter drill, and it is used to create a dimple or notch on the crest of the ridge at the proposed implant site to avoid slippage. Then a pilot drill 2 millimeter in diameter with a predetermined length. After that, the sequential drilling is performed until the final drill is used, which is 0.5 millimeters smaller than the implant diameter. The implant is rotated less than 30 RPM into position by a low speed, high torque handpiece or a hand ratchet. The implant should not require a torque greater than 35 Newton centimeter while threading into position. The implant is usually inserted slightly above in a one-stage surgery or below in a two-stage surgery, the crest of the bone, depending upon a two-stage or one-stage surgical approach. Implant is removed from the vial and avoid touching the sterilized implant surface before inserting it in the bone. The implant is inserted in bone using ratchet or with the handpiece as we discussed, and of course the cover screw is placed on top of the implant body, and then the flap is repositioned and sutured. Why is the sequential drilling is important? We have many reasons, like it reduces heat generation and allows correction of angulation of drilling after using the first drill. The direct flapless one-stage surgery. The one-stage surgical approach may be modified with a direct flapless surgical approach. This technique does not reflect the crystal soft tissue. Instead, a core of keratinized tissue is removed over the crystal bone. The implant osteoarmy is then performed in the center of the core of the exposed bone. This technique requires no suture around the PME. The advantages of this technique are similar to a one-stage surgical approach. In addition, there is a less soft tissue trauma because the tissues are not reflected. As a result, discomfort, tenderness, and swelling are usually minimal. The medications, for example, antibiotic prophylaxis for 5 days, analgesic and anti-inflammatory for 3 days, and chlorhexidine mouthwash for 7 days. In the second stage surgery, a crystal incision or a punch drill is used to expose the submerged implant. Then the cover screw is removed and the healing abutment is placed instead of the cover screw for 2 to 3 weeks. Then the abutments are then placed instead of the healing abutments. Finally, impressions are taken to fabricate the final prosthesis. The prosthetic procedure. We have the direct impression, the closed top tray impression technique, and the open top tray impression technique. The direct impression, the abutment is prepared intraorally and an impression is taken. The closed top tray impression technique, a healing abutment is removed from the implant and the transfer coping is connected to the implant. Impression material is then injected around the transfer coping and the transfer coping is unscrewed from the implant body. Attach the implant analog to the transfer coping and place them back into the impression. The impression is sent to the lab where the abutments are reduced and path of insertion is adjusted. The open top tray impression technique is the same, but the tray is open to avoid misplacement of the transfer copings in the impression. Abutment selection. Custom abutments or prefabricated abutments. A custom abutment is one in which the practitioner must make either a tissue or a bone level impression of the implant with the help of a transfer impression coping. A prefabricated abutment is machine made, seated and torqued on the implant. When arriving at the office for restoration of an implant, the patient will present with a healing abutment screwed onto each of the implants. It is at this time when a determination is made as to whether to use a custom or prefabricated abutment. There are some instances when the use of a prefabricated abutment is contraindicated. For example, there is insufficient interocclusal space where the abutment would not have sufficient height to retain a crown, or the implant requires an angle of correction greater than 15 degrees. The collar height is more than 1 millimeter greater than the largest collar height offered by the manufacturer. Angled abutment. It is available in angulations from 10 to 30 degrees. It improves aesthetics and it is used to correct path of insertion. Of course, increase in angle will cause increased risk of fracture. It is placed as deeply as possible with most favorable axis orientation. Screw retained or cement retained. The advantages of screw retained is it can be used with limited interocclusal distance and the absence of cement under gingival tissues, which is a potential irritant. Also, predictable retention and retrievability. The disadvantages: screw access, compromise of occlusal function, also aesthetics of access hole. The cement retained, the advantages of cement retained: passive fit of the implant crown, aesthetics, ideal occlusal form, flexibility of fixture placement. The disadvantages: subgingival cement line, also cleaning of excess cement, and the crown retention. So basically the crown retention is better in the screw retained. Thank you so much.